Okay, good evening, everyone. I will call to order the Human Resource Committee meeting for today, Thursday, February the 26th. And thank all of you for coming. So we're going to follow the agenda. We have no citizens wishing to speak. Our next will be the approval of the minutes. Are there any corrections to the minutes? If there are no correction, I'll entertain a motion for approval. All right. All right, it's been moved and second. All those in favor signify by saying aye. Aye. And those opposed by nay. Motion passes. Next, we have our Human Resource Committee update. I'm seeing who's doing it. Am I on the right page? Okay, approval of the minutes. And so is this a different one than I have? Okay, this is old. All right. That's, I wrote all over it. Okay, all right. Next, we will have on the agenda is Dr. Assad for the physician workforce outlook.
Earlier too.
So would y'all print me another? Yeah. All I have to do is the bottom page.
Hi, how are you?
Hello.
Good. Thank you. Thank you very much for having us here. And before we get started here, just want to preface this and set some context. Dorothy, you and I have had some conversations, and as we look at workforce and what the needs are going to be, and as we start in our strategic plan, it becomes important for us to look at where we need to begin developing that workforce pipeline. And so internally, we have started to look at where we may have current shortages, where we think we may have some future shortages, just based on how technology is changing. Are we going to have to retrain some of our current workers to do other work? So a lot of that is going on across the organization. And I'd like to thank Dr. Assad and Dr. Elliott for being our champions and working through what some of those workforce challenges may be as it pertains to our providers and needs for the future. So I just want to set that context. Thank you.
Dr. Duncan, and thank you, Mr. Bose, for having us here. We are today here to present what does it look like when it comes to physician workforce all the way through 2036. So it's really looking ahead about 10 years. When we look at the Texas health data by DSHS, one thing is clear that there are going to be some challenges which we are going to see when it comes to physician supply and demand. Some of the highlights suggest that the highest unmet need is going to be seen when it comes to medicine-linked subspecialties. Also, another thing which is not surprising given the increasing aging population is the geriatrics need. By 2036, it's projected that it is going to be the gap will be about 84.5%. And with that, obviously comes in, as you can see, that if there is going to be a supply-demand gap, that means access is going to be a problem, referral capacity will be a problem, and hence the continuity of care. And we don't exist in a silo. We are part of the system. So if this is the projection for North Texas, that means that it is in some way, shape, and form have its implications when it comes to our recruitment, our retention, and obviously hence our pipeline strategy. Okay. This is a snapshot. Again, I think one thing has to be remembered here that this is snapshot taken at this point in time. So this is the projections that are made in 2026 January. How is it going to look if everything remained the same and the supply and demand continue to increase as it is increasing? And we are not factoring in any other unforeseen circumstances that may happen. How will 2036 look like? So this is how it's going to look like. The highest gap is going to be in general internal medicine. There is going to be a gap with family medicine. However, for us, we have already strategized. We have right now the #1 family medicine residency program. So while this projection is true for North Texas, it's not going to be true for us. We are going to see a need with endocrinology, cardiology, geriatrics, and some other specialties. When we talk about other specialties, and Dr. Elliott can help me over here, but that takes into account neurology, PMNR, psych, and then where you see the bars under the 0 line, which is pulm critical care and gastroenterology, it is projected that there is going to be a surplus. But you'll keep hearing me say that over here again and again, that if even we are seeing a surplus regionally, that does not mean that we may see a surplus also in JPS, because it ties into a lot of other things. This is just supply and demand for North Texas. That does not mean that there might not be we have food deserts. That doesn't mean that we may not have desert even when it comes to specialty supply in certain areas. And of course, it is county hospitals are not an easy environment. That was a snapshot. This is a trend line. This is the trend line for the next 10 years. Clearly, as we highlighted, geriatrics is going to be the highest gap at 84.5%. General medicine, closely following, the gap will increase to 60.2%. Family medicine and primary care. Again, this is a snapshot for North Texas. Not every person, not every place is as fortunate as us to have a very solid family medicine residency. Hence, for North Texas, you're going to see family medicine and primary care as a gap. And as mentioned, subspecialties like endocrine, cardiology are going to show some persistent imbalance. And this is this model, while we are sharing, again, to reiterate, while it's showing that there is going to be surplus in certain areas, we have to remember that there are a lot of things that play into it. Just because if we are saying, for example, pulm and critical care is going to be sufficiently present in North Texas, access is dictated by a lot of things. Doesn't mean that if North Texas has surplus of something, the distribution is equal. And also ties into the operational capacity, because if you are having issues with referrals, wait times, those operational inefficiencies could equally, in spite of having surplus, continue to feed into supply-demand mismatch.
Can I ask a question?
Yes.
So all this data comes from the state of Texas. This is just, I mean, these are their charts basically.
Yes.
Okay. So they're saying today that there's like about a 78% gap in gerontology.
Yes.
So, I mean, another way to say that is we could have almost 5 times the number of gerontologists here today, and there'd be a job for all of them. There'd be a need for all.
Okay.
We just don't have any gerontologists here at all.
Very limited.
I don't know how many. This doesn't show the raw data. Is that we need 10 more? We need 1,000 more? But and it could be that's a small population of doctors to start with. But if you look at the family medicine, it's saying that its gap today is 34, 35%. I'm just looking at the chart. There's not, can't see exactly what the number is. Which means we could use 50% more family doctors in North Texas right now than we have.
Other places do have.
With supply and demand, we know that would mean the cost of providing family services would be rising. You don't have enough supply to satisfy your demand, and you would rise until there's a balance. Why isn't that happening with any of these specialties you want to talk about? But why is there a shortage? Because normally shortages are resolved, whether it's gasoline or doctors, or anything, by the market.
So I think that's what we're trying to lead to as part of this presentation. kind of how do we now close that gap?
What's causing it then?
What's causing it?
But Councilman,
So I can jump in here. It's multifactorial. So, you've got to kind of think about the continuum of education and how we actually get the supply of physicians, and there's multiple factors. So there's the U.S. factor that we have our U.S. graduates, and we still haven't necessarily caught up nationally in terms of our graduates from medical school and entering into the different specialties. So when you look at the national data, there are still definitely projected gaps in terms of deficits for physician shortages that we're definitely predicting nationally because we haven't quite caught up to that. So there's definitely a national shortage. There are some things people are looking at in terms of the international graduate component too, but that also has a different pathway, and you still have to do residency at this point. They just did pass in some states, including Texas, alternate pathways for international graduates to try to get licensure, but that's a different thing. It's not even fully up and running yet. They literally just passed the state legislature September, so there's still some rules around that are still trying to be kind of teased out in different states around that. So I think it's just basically in terms of our graduate population, in terms of medical school grads are still very short. We don't have enough. And then they make the decision in terms of which specialties they're going to go into. And there's a lot of factors that go into student decisions in terms of which specialties they're going to do. We still have specialties that are very competitive that a lot of them want to go into, like, say, emergency medicine. I'm going to just look at Dr. Kirby. She knows that it's a great specialty. They have, and they're actually not showing they're showing that probably a surplus of emergency medicine that's going to be here in Texas and around. But there are other areas that maybe not as attractive to our students that tend to have a little more challenge. So your generalist population, your generalist specialties like, as you see here, general internal medicine, family medicine, even some of the pediatric specialties are still not necessarily filling at the rate. And especially as you look at geriatrics, that's been a major challenge. And we can get a pipeline to geriatrics from different ways. Internal medicine goes to specialty in geriatrics, family medicine can go into geriatrics. And even despite that multiple pathway, we still have a challenge of them selecting that. And it's like I said, it's multifactorial. Maybe it's also related to compensation models around that. Yes, I think costs have kind of gone up around different specialties, around the cost around that. However, we're just still not keeping up with that in terms of the national pool that's feeding into our physician workforce. So we're not immune to it here in Texas, and we're definitely not immune to it here in Fort Worth and in Tarrant County. And especially, I think, for safety net systems, essential hospitals across the country tend to have a little bit more of a challenge in just making sure that we're attracting folks to come to us to serve our patients too.
Physician shortage is not new. It's always been there. It just keeps increasing. There are just not enough medical school. And if you look at subspecialties, people are going to want to go into subspecialties which are lucrative. And you can't really ask them to do specialties which are not as lucrative for many. Like look at general internal medicine. There's a shortage of general internal medicine because a lot of internal medicine doctors want to go into subspecialties, but subspecialties also which are lucrative. That's why you see surplus with pulm critical care, procedural based stuff, cardiology, but then again, just because it's surplus in North Texas doesn't mean that it is surplus here, as pertains to our own areas. But the shortage has always been there.
It's an ongoing issue for sure.
okay.
But great points.
When we look at JPS, we have a very hard time right now in recruiting neurology, rheumatology, interventional cardiology, general cardiology, dermatology. And this is not just only unique to us. Most people have hard time recruiting for these subspecialties. We more so because we really don't have, at this point, an internal medicine residency, because a lot of these are rooted in internal medicine residency. When we look at a long-range view, about 3 to 5 years from now, it seems like we will also have a need for nephrology, pulm critical care, endocrinology, interventional cardiology, and gastroenterology. Questions? And all these are internal medicine.
These are all internal medicine, okay.
Go through a pathway.
Internal medicine is the pathway for all of this, okay?
And I can clarify that. For the majority of those that you see there, neurology and dermatology, you don't necessarily have to have a core internal medicine program for those two, but the majority of those, yes, you do.
Okay.
Is there a reason maybe it's the next chart, but you don't have any surgical specialties on here.
We, go ahead.
No, Dr. Daly.
I was just saying, I think our focus was really looking at our gaps in our internal medicine specialties. That is something we can always look at in another time.
So this really doesn't contemplate the surgery needs. This is just the.
Yeah,
Right,
Just medicine.
just medicine needs.
And subspecialties.
and I can bring that back on surgery as they look at those specialties. But this is the high priority that we are hurting in right now.
Biggest.
Just the biggest one.
Do we have openings we can't fill right now?
Dermatology. I believe dermatology's been a real
Yes,
challenge. since I've been
dermatology,
here.
neurology,
Mhm.
rheumatology.
Mhm.
Do we have any openings in internal medicine we can't fill right now?
Dermatology,
Just general internal medicine.
general internal medicine, no, subspecialties primarily.
Subspecialty. And dermatology is a subspecialty of internal.
Dermatology, it's considered usually within that, they have to have at least a 1 year internal medicine experience, like a transitional year or preliminary year. And that's how even a lot of them come to our transitional year program that we have. But it's also, it's not boarded through the American Board of Internal Medicine. It has its own board. So that's why, even though it's related, it can be a standalone, but it just needs to ensure that you have the proper internal medicine experiences available.
So are all 10 of these fellowships off of internal medicine, or I guess in case of?
They're all internal medicine linked specialties and subspecialties. Yes.
None
Yes.
of these has their own residency.
Well, they are all fellowships. So let me just kind of say, so dermatology is a residency, neurology is a residency, rheumatology, and cardiology, interventional cardiology, nephrology, and those others are subspecialties. And so those go into fellowships, and those require that you complete a core internal medicine program first before you actually are able to seek fellowship in those.
So these, which ones again are the residencies?
Neurology and dermatology.
Just those two. But don't those kind of branch off of a transitional year?
Dermatology and neurology can. Neurology can be a 3 year with a transitional year or a 4 year standalone. Dermatology needs a 1 year, and then it'll have their core program.
But dermatology normally would be a 4 year.
Yes. You're welcome.
Right, I'm going to hand it over now to Dr. Elliott.
Okay. Thanks. I'll go ahead and take the clicker. Thank you. So as we think about those projections that Dr. Assad just presented, one of the things that is to think about our strategic consideration, how to meet these subspecialty needs. What we have here are 4 considerations, and what I'd like to share is that these 4 considerations are not necessarily mutually exclusive. We could think about doing all 4 or just one or the other. So, but we want to be able to have that conversation around what the options are to be able to move forward to consider meeting these specialty needs and subspecialty needs. The first one that you see there is whether JPS would sponsor its own internal medicine residency program as an internal sponsor. We are a sponsoring institution, of course, for 12 residency programs currently, and this would give us the highest control, more of the long-term pipeline value. It has the highest startup lift, but we've done some evaluation of it already and know that there are some opportunities there for sure. The second that you see there is not uncommon in some places, is a consortium model or a partnership model with other hospitals or academic partners that actually do have internal medicine established already. And that requires, of course, legal and compliance considerations, but you'd have to figure out your shared infrastructure and governance around that. There are established internal medicine programs in the DFW area that you see listed there. Locally here in Fort Worth, Baylor All Saints has started one a few years ago. Texas Health Resources has one. And of course, in our other areas, and also Medical City Fort Worth in a consortium model already with HCA. And then there's Methodist and UT Southwestern. They have core internal medicine programs along with other specialty fellowships already there. The third option that you see there is considering, do you start a program that doesn't necessarily have to have a core internal medicine program? That was where neurology or dermatology that I've just mentioned. they do have prerequisites for having internal medicine experiences or a transitional year program. So that's not on, that's not unusual to see that happen. The thing that I would say a little challenging about that is that there's still a heavy lift with that because you still have gaps in terms of the physician, attending physician and faculty who are available to be able to do that, because you have to have the program director, the faculty in place to be able to do that. And since that recruitment is still a challenge, that may be a heavier lift to think about starting a program. But it could be a draw. All right, and then the fourth one that you see there is something that I do recommend that we move forward, and I think we've got some opportunities there, is to even actually get a full GME expansion assessment and see where we are with our current programs and future programs, and really look at some alignment with our physician projections and workforce needs that are very much specific for us in terms of Tarrant County, not just in terms of the global piece, but think about what that could look like to build a strategic assessment and to create a timeline and look at what we can do to build this and get that kind of external perspective, consulting perspective. And so consider putting an RFP to be able to get that information. So these are four, like I said, they're not mutually exclusive. All four are all options on the table. So if we were to think about an internal medicine residency here, thinking of that, and to the point, building those subspecialties, the majority of subspecialties and fellowships require that the sponsoring institution, whether themselves or in partnership in a consortium, must have a core internal medicine residency program to build fellowships. So the strengths that we have in terms of what's here already is that we do have a very robust volume and capacity in terms of our patient volume, and building an in-house pipeline does align to helping us fill that gap. We have the clinical complexity, as I mentioned, and the volume appropriate for internal medicine training. And we also have a platform for those specialty recruitment over time. The opportunity that we have here is to create a plan, a graduate medical education plan with internal medicine that can support our priority service lines and that continuity and access and referral capacity that Dr. Assad just mentioned. And I will say it improves your recruitment and retention. I will just say residency programs don't necessarily, give you the pipeline for all recruitment, but it's very helpful for that. And it does attract faculty that are interested in doing that kind of work and academic work and practicing in that environment. And of course, graduates often will look at their own home program that they practice in to consider practicing. So that's a train where you practice model that can sometimes be helpful in recruitment and retention.
Dr. Elliott, it's a very good tool for recruitment of faculty because they
Yes,
often will
right.
ask that do we have a residency for internal medicine? Because that's a big drive for people, frankly, when people choose us or choose working at UT Southwestern.
A lot of your specialty.
Yes.
Yeah. Faculty, yeah.
For example, if a rheumatologist wants to work here, they're going to want to know, do we have an IM-based residency over here? Because they usually like to go and work at places where they'll have an exposure to IM residents. And that's why we have lost some of our attendings who basically have chosen to go and work at UT Southwestern because they'll have that exposure over there.
Working with residents is definitely a draw, I will say, for many, and Dr. Kirby's nodding here. Working with residents, people enjoy it. I mean, I'm going on 30 years almost of doing that myself, and it is definitely an appeal to be able to have residents and residents also in your specialty to be able to work with too.
Before we leave that page, you said that there was a current internal medicine residency at Texas Health Resource, Baylor Scott and White. Even having those, that hasn't helped us in our recruitment.
So the way I will say, it has been helpful in some capacity, but not necessarily in all capacities. It depends on the fellowship and what's there. So I will say for HCA, Medical City Fort Worth, we have had a longstanding relationship with their gastroenterology fellows rotating here, and we've actually hired quite a few. So I think to the point that Dr. Assad makes, when you do have a relationship or a fellowship program in that, it does allow them to think, hey, I've worked in this capacity, I've worked in this organization, in this system, I may like to stay here and practice. Okay. So it is a draw. We will be having also Baylor All Saints Gastroenterology program. They're starting their fellowship July 1st, and some of those fellows will be rotating with us, but that's brand new. So otherwise, for the internal medicine in general and other specialties, I have not necessarily seen that.
Okay.
But I just have that one example of
Okay.
GI
All
I
right.
can mention.
Okay.
Dr. Assad, anything else on that?
No, I think GI is a good example.
Okay, thank you.
Yes.
I'm a little bit confused here. Is what are we trying to do? Are we trying for recruiting, or do we want to expand our residency program? Because at the end of the day, we have to transform all that stuff into what's potential revenue?
Mhm.
How do we justify all this stuff? Are we providing services for the unmet needs for our population? What would be the number of patients that we will be treating here? Is it there? If we're going to go out and look at, because I hate to go
Sure.
back to the old blue ribbon where all the data show the population. We're not Methodist, we're not SCAs, we're not Beta Scott and White, so that population shrinks down a little bit more. So the standard numbers that make sense if I'm like Beta Scott and White, then makes sense for us sitting here, unless we want to say we're going to go after that unmet also provides third-party insurance. And if it's third-party insurance, how do we, can we put them all in the same waiting room, or do we have to have a different facility to attract the unmet for the county, or do we want to this mission alone? So those are some of the things.
We have very basic unmet needs. Like for our patient population, we need neurology, rheumatology, cardiology, dermatology. We have like one dermatologist right now. I think, hired our second neurologist. If even one becomes sick or something happens, we just don't have these are not very highly subspecialized needs. This is just very basic needs which we are struggling to meet because we just don't have enough. We don't have really a recruiting pipeline. We are looking at nationally to find a rheumatologist or neurologist. But if we had an internal medicine residency here or we had fellowships over here, it would be a very different scenario.
And I think,
To answer your question, if we just look, the confusion part for me is that if we trying to do that to take care of connection population and
Right.
stuff, then that's just a matter of recruiting and get the right attractive package and all that stuff. But if you're trying to do it that way, you're talking about multi-million-dollar setup for the residency program, all that stuff to serve that needs. Yeah. I'm just confused to where do we balance that? If we're gonna go all out, let's go all out and build
But-
for private patient also as well and expand all that stuff for the needs of the county rather than the needs of our population. So that's the only thing.
Well-
I'm a bit confused there.
I have a comment on that.
Mhm.
For JPS connection patients, you already have a waiting time to get them into subspecialties. So our deal that I'm looking at is to meet that need. That need would help us increase access for our own patients. Because right now, if you call for a dermatology appointment, you might get it in 6 months. So if you look at our specialty wait time, we have an extended wait time for our patient. So the program that I'm thinking about is creating something that would help us meet our needs with our patients to increase
Oh, no.
access.
I have no doubt that's what we
Okay.
need. I think mine was more of strategically. If that's the need, is it 1 million, 2 million? But if you stand up the whole program, you're looking at $40-50 million.
I think if we look at it the same way we had this discussion when we decided to start internal medicine, the ER,
Mhm.
there is a cost. We looked at it and we decided what is the best way for JPS to be able to meet those needs. And I think what they are looking at now is presenting information that says we have a need that we can't fill. And this is something that we need to look at recruiting. And I think internal medicine it's the hub that you have to have that to be able to reduce some of those waiting time for other specialties. So I would be looking at something like, what would it cost for us to do an internal medicine residency? That's kind of what I say.
No, I fully agree, because if we're gonna go down that path, all I'm saying is that, do we need to look at a bigger picture, so that we can, this, from the data show, there's unmet needs for all patients. And not just us.
Well,
So,
That's the case. How do
Sure.
we expand our clinics and all
we
that
can't
stuff?
accommodate ours.
Because that's a
Sure.
whole new ballgame for us.
Okay.
yeah, totally.
That can reduce the burden on tax down the road if it's a successful, and we can bring, because we look at before a certain percentage of commercial insurance come up, that it's a lot of money from that side of it to offset some of the stuff.
Yeah.
I just don't want to just look
Sure.
at needs, look at the extension.
And I want to just be clear too, it's not all or nothing, right? It's not that you have to do every single list of those that are on there either. We need to be very strategic about this, and that's why I really put these 4 here, and that's why I think it is good to get it. It's time. It's been 10 years since when we did a full evaluation of this, right? And I was part of that process coming into that, and thankfully so. And so I do think it's time to look at the data and make data-informed decisions around this strategy, around our growth in graduate medical education, and how we align to our physician workforce needs and shortages here in the area, and target it and be very focused on also what JPS specific needs are around access, wait times, referral capacity for our patients, and understanding all of that. So I hear your point. I don't necessarily see this as the big lift, like we're going to, all of a sudden, the big ask is $40-50 million. And every program can be variable in size. We're not necessarily talking to the same level of size of what we have currently in family medicine. You can have a core program of 12 and still build upon that. But you have to be strategic around what we roll out. For instance, like we went back to that slide that showed, endocrinology and cardiology may be one of the biggest lifts, or it could be one of the things we think about. And so I don't know, I'm just throwing that out there. And that may be where we say, okay, here's an opportunity to start with. It takes time. This is a 10-year minimum journey to even get to that. And it'll take time to build the core program, and then you strategically align your fellowships based on that need. And what happens is that I will tell you, if you look around here, you get an incredible caliber of physicians who who also want to teach and are in academics and research and scholarly activities and things like that. That clinician, educator, scholar, physician is an incredible recruitment when you have residency programs that align with their interests and their ability to move that forward. So I hear you in terms of I don't think that doing GME expansion is exclusive of looking at your overall operational organizational strategy around physician workforce needs and development.
I understand.
So I agree with you that you need to do both.
I understand all
Yeah.
that. I think what we need to look at that by 2036, right? If that's the unmet, how much of that will be our revenue, right?
Yeah.
We're going to be a $1.7 billion spend hospital system.
Sure.
We're going to be a $3.5 billion by that time. And how do we align so that we can get the population? Do we go and just open it up and they come in as they please, or do we engage and we negotiate contracts with managed care so that the flow of patient coming in that would utilize the service that we provide and all that stuff.
Sure.
But if we just provide that, just in small increment, we won't get there.
Understood.
A couple of comments before I talk about specific residency programs. And Dr. Elliott, you and I have talked about this since I first met you. I'm pro-growth. I'm growing your GME program here. I think I want to see JPS be a leading research institute in the nation. It's my understanding we really haven't provided the facilities that you're going to need in our $2.5 billion program for all of our current residents. Is that true? Maybe I'm mistaken, but I've been told there's not an auditorium or training rooms, things that other research institutions around the country have.
No, it's not true.
No.
Is that Tell me what
We're
we're
even
doing.
talking about getting an auditorium named, so that's not true.
Can you give me a little,
Sure.
tell me what you know about
Sure.
what will our facilities be for your current residents?
Sure. So what we currently have absolutely does meet our accreditation needs. Actually, all of those things in terms of the resources, infrastructure, is a requirement of meeting accreditation for the ACGME. And if you don't have that, you actually can be in jeopardy of losing your accreditation. All of our programs have continued accreditation. Many of them have commendation. Now, to your point, is there limited capacity currently where we have? I think everybody will agree their space is always limited, but they actually do still have the space that they need, or we find them contracted space that's able to be utilized or shared space to be utilized. So all of that is there. Now, as we look at the new hospital, I will be I'm going to say I'm very grateful that we have been very much at the table, with every single program and every single programmatic graduate medical education need. And it is part of the new hospital. It is going to be definitely even more than what we currently have and definitely meet the needs we have. And it actually, I think, also gives us an opportunity for some growth. So yeah, I've definitely been very involved in those discussions around
And
that.
all the individual programs have a seat at the table also?
Yes, we've met with each program multiple times. My office meets with them multiple times. Every program director, we know their team rooms, we know what they've asked for. We do budgets with them every year. We're in budget discussions with them every year. What are your needs? What are your resource needs? That is an ongoing discussion. That's my position as the designated institutional official, to ensure that we are getting that input from every single program. Now, does everybody have extra wish lists and things like that we can look at? Absolutely, we all do. We look for opportunities to grow that in the future, but I will tell you, we are definitely sufficiently looking at the new hospital. It'll be really great. And I even can tell you from the graduate medical education space, with the input from all of our programs, it's going to be pretty spectacular.
And are these facilities, in blueprint form that you could actually, I could come by and visit you sometime?
Personally, I will leave that to our operations team, but everything is good to go.
And we are very
I don't
grateful
have those
Dr. Elliott has been part of all these construction meetings.
Absolutely.
Every floor in this hospital has a dedicated GME. Actually, they were the ones who actually
Yep.
got the place first assigned, because teaching is a great mission for JPS.
Yeah.
And after that, we have actually attendings were saying that, look, the residents have actually so much more space than us. So they were definitely a priority for us.
Every floor, every bit that's gone into it, I've been a part of that, yes. And the program directors have given input, residents have given input. So, yeah.
All right, well, I want to make sure.
Sure, great question.
We need,
Yeah.
for these programs, because we're going to be adding programs over time. And we tend to hold on to our buildings for half a century.
Yeah.
So, in growing your GME program, I think and this is kind of what BT was talking about. I think
Sure.
we need to be tactical.
Absolutely.
And one thing, and I don't see the 800-pound gorilla in the room, so I'll just be the 800-pound gorilla in the room. We have to be careful with internal medicine that we are very mindful, respectful, considerate of our family medicine.
Absolutely.
Family medicine and internal medicine, this is national. They're rivals. Let's just be honest. They're rivals. And the heart and soul of our GME program here is our #1 in the nation family medicine program, which they just do a fabulous job. So they need to be definitely at the table as we go down this path. And 50 years from now, hopefully we'll have every GME program that exists. We'll
I
have
don't
a
know,
whole-
but
a whole menu here at JPS. But as we go down that path, we need to work closely with the family medicine leadership to make sure that, we're not stepping on their toes and just not messing them up. We need to work together. There needs to be a dance as we grow, a respectful dance. And not just superficial, but a deep, respectful dance with family medicine. That's something I want to bring up, because they are the largest program we have here, and I think they're the largest family medicine program in the nation. I think they bring on about 24 new residents a year. So some of these programs you talked about in your third column here, you you didn't mention, you just gave examples, dermatology, but dermatology could work also.
Work in terms of,
That could be something you're considering with the dermatology residency.
it's something we can consider. I'd like to really understand the market first, and that's why I think understanding some of this from an external view and consulting can be helpful for us. Because here's one of the things, you'll see the last line on this slide. We have to align our growth with the accreditation standards and our operational readiness. The last thing we want to do is to start something, and then what we do is we submit this, and then we don't have the support to be able to move it forward. And so that's why you're right. It's a very stepped approach that we need to be able to do this. And so even if we consider dermatology or neurology, even with a timeline, there's things in place we need to make sure before we even submit anything for that. And so that would require a full assessment. It's just one for consideration.
If you were to start a general internal medicine residency program at JPS, how many years would it take to get it to where you had your first class coming in?
I've got a timeline up there on the last slide, so I'll get to that in a second. I'm happy to share that with you. Yeah. And just a comment too, fully support. So just, full transparency. I'm a board certified family medicine doc and proud of it. I'm also a leader. I'm also an organizational institution leader. I'm also an executive. I'm also a strategic thinker and someone that understands graduate medical education from a local, state, and national level. And I've worked in 4 different systems. This is my 4th kind of teaching academic system that I've worked at in 30 years of my career. And I will say, I understand the push and pull of family medicine and internal medicine. It's not easy, but I also think there are strategies that you can do to mitigate that. And I do agree that we have conversations with our leaders and our family medicine leaders, and we make sure. And I think also from the residents and everyone else to ensure, like, what are those things to ensure that we remain incredibly competitive? We remain at number 1. And that what are the things that we can do together to really advance this? And there's some things that we think we can do to do that. I think family medicine residency here has an incredible reputation and legacy that will continue for years to come. Any program that you build in and pull into this needs to be supportive and collaborative. I think these are the same conversations that likely happened, and Mr. Bose can help me chime in here, when you had emergency medicine coming on board. When you had OB coming on board 30 years ago, same thing, right?
Same thing.
And
Yeah.
look at that now. So you have to be able to have those conversations. We are a multi-specialty organization that needs to serve our patients in all capacities. And I want to ensure that our learners get exactly what they need, every learner, from orthopedics to family medicine to everyone. So I fully agree with you that they need to be able to be at the table, keep them number 1, make us competitive. We also need to serve our patients, and we need to work together and figure out ways to do that.
And the other thing I will say, Dr. Elliott, is that there is no path of FM, no matter how good they are, it doesn't lead to cardiology. FM does not lead to GI. There is no path from FM to go into that subspecialty. And at the end of the day, we have our patients to take care of. And if we choose to shut our eyes, because when I came, like Dr. Elliott, 10 years ago, I came in, I was told there's going to be an internal medicine residency. I came from Brown. I was an internal medicine academic attending there. I came here for that purpose. I don't know if I didn't know about JPS at that point, but I saw a huge potential. I said, yes, that would be the right place to do an IM residency. 10 years fast forward, we're still having the same conversation. The gaps are not new in cardiology, GI, neurology. They're still there. And if we don't do something today, I assure you 10 years from now, we're going to still have the same conversation. And you know who's going to suffer? It's really going to be our patients. Our wait times, whatever they are today, they're not going to get any less.
Okay.
Our family medicine residency is number 1, no doubt about it. And I think we owe it to them that we protect that.
Yeah.
But there are ways to do it. At Brown, we have side by side IM and FM. I did not think any differently about that. I think it is upon us that if whatever model out of the models which we listed, that the organization feels is the right path to get to that subspecialty need,
we protect our family medicine residents.
Okay.
For me,
Ms. Ferd, did you say you moved from Brown to JPS? It's been 10 years now? Thank you for your service. First of all.
I love JPS.
Okay.
But you had in mind when you came here, starting an internal medicine residency?
I was actually, at that point, I
Really?
was hired to do that.
Oh, wow.
We've been
It's
talking
been,
about
it's been a
this for
discussion for years, but it has not been a discussion at board level.
Yeah.
That is different. And that is why it is here at HR, because we have to have some strategies. And part of that is just like we look at nursing and the rest of the physician group is something. And so this is the first step of elevating it up so that there will be some support after we get proper information. DT, you had a question?
I think it's the right way of looking at it. We've been looking at, thinking about it for a long time, discussing it, but we never. I think we should separate. I think as long as they know they are in the same pool, but they don't swim in the same lane.
I think that,
By separate that,
Yeah.
that they see a separation there, and I think we can do well. If we don't have internal medicine, there's no way we can support our aging population. I mean, they need cardiology, they need pulmonary, they need all kind of stuff, GI and all that stuff. So,
okay, you want to do your time?
Sure. Thank you. All right, so I think next steps, we're going to, honestly, I really do think having an external consultant kind of model around this, really targeted around this particular issue, will be helpful for us. So we can also clarify what the surplus assumptions mean for us, right? And for specifically for us at JPS. Also in that, it'll help us to define, kind of create a potential timeline and strategy around that growth and defining what faculty and infrastructure requirements will be needed. And then ensure that we've got the proper access, clinical access there too. And to your point, though, is also that we protect our existing residency programs and experiences. We must do that, and not to the detriment of any program. Also developing a strategy for some competitive recruitment market. I think what you said, DT, was important. It's important for us to understand that and the rising compensation pressures. And I will say to your point too, Blake, that healthcare costs have risen significantly in the last 10 years too. And that includes some of these other expectations around compensation. So we just have to look at it together and see where we go.
When you say healthcare costs have risen, how does that affect your GME plan?
Because with all those costs also trickle down to how do we support our residency programs and all of the things that they do. So everything from,
Salaries.
from salaries, infrastructure, patient care, all of it too. But I will tell you, we do look at ways to fund that, and that's where some of those things happen at the state level and the federal level, where we are able to look at opportunities for funding models around that to offset that.
But there's some revenue offsets.
Yeah, those are the revenue offsets, but
They don't cover them.
they don't cover us fully. No, we have to look at our costs that go into that. So we have significant cost too that goes into
So when
that.
you do something like this, you put together a pro forma.
We do. Yeah, absolutely. For every single program, every single expansion, we put together a pro forma and we put together a full proposal, and we look at everything to even start to see, can this even meet accreditation standards and what the pro forma looks like, for sure.
Okay.
Yeah. And I can get into GME funding a whole other time, but not.
Yeah. I'll bring you back to that.
There you go. It's a whole thing in itself.
what is the likelihood you think you'll be able to put something down and make this into reality? The program has been around since Southwest Airlines and the rail trying to put a rail people connect the cities in Texas together.
So as far as, help me understand a little bit in terms of, this is a proposed timeline. This is something that we just had to put out there just for some consideration. I want to kind of understand your question a little bit more in terms of the layers of it, in terms of execution and implementation.
Execution and political.
That part.
Invite.
Yeah.
The word this. I mean, that's why I was
Yeah.
joking with Southwest and the rail system trying to connect rapid rail.
Yeah. I think those are still the ongoing conversations, right? I think that's the thing, to continue that. I think logistically, we've started programs here since I've been here. I mean, we can do programs. We do assessments. We We check everything from faculty needs to staff needs to volume. We look at everything that goes into that to see if we are a readiness to do that. And so to start any program, and we do an updated proposal and budget, we do the whole thing. So logistically, this can follow a timeline. This is a timeline that we proposed. To your point, those other kind of layers of those conversations to have and that buy-in and those types of negotiations would need to be ongoing and discussions and see what points are brought up at each stage and try to figure out ways to address those. So this is just, as you see here, to your point, to a timeline. If we were to look at this, it does need some infrastructure. And Dr. Assad can talk a little bit about that. You'd have to look at your internal medicine department and see what we have in place and who we have in place to be able to do this and if we have that. So that requires an extensive review. We had put together a previous proposal, draft for the program, for the accreditation submission and a budget. We'll have to revisit all of that because it's a couple years old. Things shift. But we always look at that. We have some other funding to your point. We actually have some other opportunities around revenue that we need to look at that we're still waiting to get some information on. But we'd have to update that, and that probably will take several months to do that. So that's why I put kind of October there to do that. One of the things you have to recognize that any new program, any new residency or fellowship program, as per ACGME requirements, must be first approved at the Graduate Medical Education Committee level. And so our Graduate Medical Education Committee, I chair that, and it is comprised of all of our program directors and our 4 house staff officers who make up a resident vote. And so that's important for us also to make sure the GMEC has all it needs to make a decision. Once that is approved, then we're able to submit to the ACGME. They put it on their agenda for review, and they will provide a decision whether or not they give initial accreditation or they have more information they'll need to gather to push it to the next agenda. If an initial accreditation is given by September 2027, then you are ready for the match cycle, which would be beginning around that time through March of 2028. Because we would need, of course, before all that, have everybody in place to be able to do that, including a program director and a program coordinator and faculty ready to go, but especially a program director and a coordinator ready to go to do the recruitment. And then match day would be March 2028, and that would afford us to have the first class that we identify July 2028. That's a proposed timeline. You can always shift those in different ways. I will say the ACGME meetings beyond 2028 are not published as yet, so I cannot predict if we have to shift that timeline when that would look, what that would look like. But I built this timeline based on the published dates from the ACGME Internal Medicine Residency Committee meetings.
What are some of the photo internally that you need to show? Is there a showstopper beside those?
Say that again.
Is there a showstopper beside those internally?
Internally, besides what you want to talk a little bit, what are the internal potential barriers or?
Nothing. We are just looking at our internal department, internal medicine structure at this point. We don't have a chair of Department of Medicine at this point. Definitely looking at leadership and looking at just in general how our different divisions of Department of Medicine should be structured. That's all underway because I think there has to be a certain structure which is primed to have an internal medicine residency. That is not there yet, but those discussions are underway at this point.
Is there I don't know anything about medicine or education from that standpoint, but is there anything that's overlapping between family medicine and internal medicine so that you can get better collaboration from existing family medicine?
Sure. Yeah, so I mean, as far as experiences go, or,
Or some.
I'm gonna ask some questions.
Thank you.
yeah, there will be rotational experiences where they will have to share those experiences and share some of those experiences. There's some that are not shared necessarily too, that we'd have to look at and see. But yes, there would be some things that they could look at for that.
This collaboration there is important too. So.
Yeah.
Blake, did you have a
Well, I
question?
did this, hearing your first part of your presentation, I thought I heard 10 years mentioned at some point. This is a fast track timeline. This is.
No, that's just the timeline,
No, that's the 10 years was, I think, the projected data that you
projected
saw.
data.
That was the Texas Department of State Health Services data is a 10-year projected.
I thought there was it takes 10 years to get things programmed.
No, I was saying to see that full specialty, if you have to do all the specialty and to build specialties, it takes a while. You have to have the core program first. This would be the core program first. To build specialties to the level that we're discussing, whether you pick 1, 2, 3, or 4 specialties, it takes time to add each specialty. That's what I was saying.
And
Sorry.
sometimes when you have the core program, if even they go off to do fellowship, they are more likely to come back to their training site.
Right. And then also realizing if you have a July 1st, 2028, they're not graduating till 3 years later. And then you still have to get through that, build your, and then build your specialties. And so it takes time.
Okay. All right, gang. Thank you for the information. And from what I'm hearing is that we know we need to have the core group. That's what I'm hearing, the internal medicine group. I realize that when you make a change, and as long as you are ensuring that the family practice program is still going to be able to meet their needs and stuff, I believe that we should kind of move forward.
Have you had any conversations with family medicine leadership with all your planning you've been doing here? Is this a surprise to them?
It is not a surprise to them because they've been part of these conversations, I think, for quite a long time. They're obviously not happy with it because their concern is, as you mentioned, that they are #1 family medicine residency program in US. Would that be affected with internal medicine coming in? But this presentation was shared with them because we don't want to do something in hiding.
They've seen this?
Yes, I went through page by page of this presentation with them. And they knew I was coming in to present it today.
So
They gave you some feedback? No, they just looked at it.
Blake, let me say this, that there will be some discussion between the groups, but I think the big deal is that if we are saying we want this to be a part of our strategic goal to move forward, the family medicine, and we maintain making sure that they have all their needs and maintain that they are #1 family. It will not preclude us moving forward to internal medicine. And the same way that when I was here, when this was an MD hospital and no DO was ever going to come in, we went through that same fight. The same way when we started the, the other physician group. It's a matter of us making a decision and saying we need to move forward. And those groups come together and we move forward. This is a strategic initiative that I believe this hospital needs.
It's, for me, it's more survival for us in the long run also as well. Look at family medicine like an engine, but you need the transmission and the brake and the fluid because you have to be able to take care of the population with high risk. And that's the only way you can move into later on to value-based care and all that stuff.
No.
Because that's where we have to be headed. Otherwise, fee for service, it's a race to the bottom.
Okay.
And can I just say one more thing, Mr. Bose, if you don't
Okay.
mind to support, just the discussion and just for context, people may not recognize is, and Dr. Assad mentioned this briefly, and I tell you, I'm a family medicine physician. Family medicine, unfortunately, through ACGME and through the American Board of Medical Specialties does not have a pathway to these other specialties that are in demand. That is just not there. The special, which is where I'm going to go with, the only ones that we can do, which we have done, and they're, we have done, is sports medicine, hospice and palliative medicine, and geriatric medicine. And geriatric medicine can be done either through IM or FM. Even now, ABIM, American Board of Internal Medicine, they are very strict in terms of what can be done through their pathways. Very strict. And so it is important just to understand that context. If indeed these specialties were available through a family medicine pathway for ACGME and through the American Board of Medical Specialties, we would absolutely pursue them. But the unfortunate reality is they are not. And we have had, and I can tell you, we have had discussions with them. I do national discussions. I know the ABFM president. I've talked to ABIM. Where are we with these conversations? And there's no movement there. No movement. So that's why I think also just to understand that there are some specialties that are trying to consider whether or not they'll withdraw from the American Board of Internal Medicine, but they're not there yet. Neurology did it years ago, so they're under the American Board of Psychiatry and Neurology. Dermatology has the American Board of Dermatology, but everything else is under the American Board of Internal Medicine.
Wow.
And
Okay.
the specialties that you're most concerned about are which ones? That flow through the town.
They would be the ones that would support a lot of our geriatric population. So you think of cardiology, neurology, orthopedics, the ones rheumatology, those things as we
Those
get
are the ones.
older that we require
We
more
need.
specialty need around.
Okay.
Nephrology.
Right. Right. Okay. All right. Excellent presentation. Now, I will ask, what will be our next step? What will be our next step?
So we will continue to evaluate where we're currently at and where it is that we're going and what that gap work needs to be completed. I think this is a reasonable timeline in getting our first cohort of IM. We will also continue to bring it back to the board. I do want to put it on record that we truly value all of our programs here, and we truly value our family medicine program. And there are many places across this country in which family medicine and internal medicine coexist together. And I truly do believe that they will make each other better. I truly do. I think when our internal medicine program comes, our family medicine will make that internal medicine program that much stronger. And likewise, I think it will help enhance our family medicine program. So we promise that we will continue to have those conversations. They will be part of this ongoing work that we will do. But we will start moving along with our consultant to come in, and then we'll update the board periodically as to where we're at.
All right. Thank you. Excellent job. Appreciate it. Okay. All right. Now, don't blame me. They took up the hour. But it was a good hour. It was a needed one. Okay. All right. Jill, you're up. And you have all the time you need. I'm not going to
Oh,
rush.
I have some of the standard updates regarding human resources, so I'll provide those. I think that discussion was worthy, though, of the time,
Yeah.
Time well spent. All right, so I'm first going to kick it off with our goals for this year related to human resources, those goals that are on our strategic scorecard. The first one, which was a new goal this year, was looking at first-year employee voluntary turnover. Right now, fiscal year 26 year to date, we're sitting at 27.08. So right now, this is a year-long metric, and so this is only a few months into the year. We're sitting between target and stretch. One of the initiatives that we have around voluntary turnover is the Breakfast Club. We started that now probably, a couple of years ago. And it's the opportunity where Dr. Duncan really kind of sets the stage for our employees. She not only meets them at new hire orientation every Monday that they have one to talk about our culture, talk about our vision, talk about a mission, our goals. But then she follows that up with the Breakfast Club. And again, the intent is between those first several months of as a new hire that they're engaging with the organization. So we've been doing that. It's been great. What we're now going to do, though, is take it up another step, move forward to a new program that's going to add an enhancement to our onboarding process. In March, we're going to implement what we're calling the Blue Ribbon Program. This is really, again, an enhancement to our onboarding experience. We know it's very important from day one that employees, team members feel like they belong to the organization. This is when visibility of leadership is super important during that really high risk turnover period in the first several months, really up to a year of employment. Mm-hmm. This will also help transition the onboarding, and it ties to the CEO Breakfast Club. And really what it is the supervisor, the leader is going to meet their new hire when they get done with onboarding. They're going to meet them over at JPOC. They're going to put a blue ribbon on their badge to signify that they're a new employee. That blue ribbon will be worn until they attend Breakfast Club, and we'll have some sort of ceremony, if you will, of removing the blue ribbon and saying, all right, you're not new anymore. Here we go. And one other piece that I didn't put it on this slide is we're going to have those new employees actually write a card to carry forward to the next new employee. And so when you're a new employee, you'll also get a card from a previous new employee with, some sort of note or thought that they want to, give away to the new employee. And so we're looking forward to kicking that off in March. We know this ties to our Gallup survey. We know communication is always important. So day one, if we're communicating and showing, those communication points between the entire onboarding process, but then really the handoff to the department. It also demonstrates, leadership cares about me. That's an important question, to really build that relationship with their direct supervisor or leader early on in the process. And then also ensuring when they're having those conversations with their new hire that they have everything they need to be successful when they first get started. So really help build that relationship in the onboarding process. So we're excited to do this across the organization.
I like that.
Yeah.
Mm-hmm.
And we like our blue, JPS blue. Talk a little bit about employee and clinician engagement. I'm very excited to announce at this meeting that we've been awarded for the third year in a row the Gallup Exceptional Workplace Award. And so truly, it's an honor. This will be publicized next week globally by Gallup. They said we are allowed to present it today in our meeting, but truly the phenomenal work that our team does, from staff to leaders, to really make this an exceptional place to be and to work. When people ask what keeps you at JPS, it's always this. It's the people that I get to work with, and to be able to take care of the patients that we take care of. And so very proud of this award. Of course, we will be celebrating. Dr. Duncan announced it to the organization yesterday, and couldn't be more proud. Just a reminder, this is not just a healthcare award. This is a global across all industry awards. And so we will be with maybe a couple other health systems. There was a handful last year. Don't know how many. There's usually around 60 across the world that participate and are part of this award. And so I'm super proud and excited to continue the great work that we're doing with employees.
Right. Awesome.
So even though we did a great job and we continue to
Great board.
we continue to better our workplace, we know there's always opportunities, and we're going to continue to drive for continued excellence. One way that we're doing that is through leadership engagement training. And so getting very tactical through some Gallup enabler sessions where we're actually going through question by question, giving them practical strategies, tactics to help drive engagement. We often learn from each other as well. So it's a great opportunity for leaders to get together and hear what other people are doing to help drive engagement in their areas. Our HR business partners are also a part of this training, and so they get to work alongside their leaders as well.
Great.
Clinician engagement. If you didn't know, clinicians take a different survey. They truly engage differently than staff. And so Dr. Assad has been very busy doing, I'm speaking about her great work, but been very busy with her physician leaders in developing plans and strategies for this next year. We know we had some opportunities with clinician engagement. She's developed, working alongside UT Dallas, a leadership development course for many of our physician leaders. They will be going through this year. Communication, again, is so important. So she has been hosting CMO town halls that many of us participate in. We provide updates on what's happening around the campus. I, in particular, talk about the MFP every time. She also has set up a SharePoint site to share communications, the recording of the CMO town hall as well. And so she's been busy with that. Another big pillar of her work is around a new clinician well-being committee. And so that group is working together to develop a roadmap that's aligned with some national benchmarks around well-being for clinicians. She is busy. Her and her leadership team is busy rounding at all of our locations. She's at a clinic all the time, saying hi and making sure that she's hearing what the clinicians around our community are saying, not just here at the main campus. And then, of course, you know, we have our annual awards event. We know recognition is very important. I have a couple of our recent award winners from our last awards event. Dina is a APP in palliative care. And then many of you know Dr. Gabash was Physician of the Year last year. And he has been a longtime oncologist with us. Other activities that we do around the organization, again, all employees engage differently. And so we offer a lot of different types of network events, as well as engagement activities to ensure that we have not only activities that are fun, but also providing communication, providing fellowship, and just some fun around not only here at the main campus, but you know, it's also important that we bring these activities to other people as well. And so the community sites, our clinics, as well as our jail employees participate in many of these events. We take them to them over the year. We also offer them 24/7. We know we have a night shift as well. And so it's important when we're doing things that we include them in some sort of activity as well. So they know that they're also a part of the network. Not everything happens from 8 to 5 on the main campus. Going to talk a little bit about workforce optimization work that we've been doing this year. Our journey started back in June of 25, and really what is workforce optimization? It really is right-sizing the workforce across the network, making sure we have the right people doing the right things in our different areas. Why is that important? 60% of our expenses comes from some sort of labor cost. And so we know that's a large expense for our organization. How have we worked through this year? You know, we have done detailed studies, operational assessments, actually doing Gemba walks and walking through the kinds of things that people are doing to identify opportunities for improvement. We've also did benchmarking. So we benchmark with other organizations like us to say, you know, where are we sitting at in this particular department as related to number of FTEs? With that, in partnership with leaders, we develop productivity targets. So those are set. So for example, you should have X amount of productivity hours per unit of service in a particular department. How do we get there? In collaboration, again, leaders with their staff and teams develop management action plans. Really, that's looking at identifying how can we do things better, differently? How can we use technology maybe to improve our workflows in order to be more efficient? It doesn't equate to staff reductions. It really equates to, I don't want a nurse transporting a patient to another part of the hospital. I want a nurse to be able to be in front of the patient, doing nurse things and working at the top of their license. And so that's really when the optimization work comes in to make sure people are doing the things that they should be doing according to their roles. And then, you know, how do we make sure we're achieving those targets? You know, we have some target dashboard tracking that we track. And we also have variance reviews that we're just now starting to kick off. And really, that's the opportunity for us as leaders to sit down and say, what are the barriers? Where can we help? Where might there be another opportunity to do this differently? We are just now getting started with those variance reviews and management action plans. Other labor efforts, because it doesn't happen in a silo, we have a very robust couple of teams that meet currently on a bi-monthly basis. So every other week, we have a team that reviews all of our FTEs. And so we're looking at every single FTE, whether it's new or a backfill, to make sure, yep, we still need that FTE. And so we're reviewing those. We're looking at their productivity targets, making sure that, they're performing from a productivity standpoint. And we may have more questions. We may bring the leader in and ask more questions about the role, or are there other things that we consider at a higher, more global level? In addition to that, we also have a labor council committee. That team meets monthly. We really look at optimization and other labor related initiatives like policies and procedures and things like that. And so that's really looking at more process driven things from a labor perspective. And then also our team and leadership team receives Strata as our tool that we look at, our software tool that we utilize for productivity and many of our budgeting activities. And so Strata education and training, have been given to leaders, and that's an ongoing process as we continue to onboard new leaders or new questions come up. Some of the future work that we're considering, I say considering, we'll always have leader education and training, but looking at future work consideration around span of control, really, what does that mean? That means, how many direct reports does a certain level of leader have that reports to them? And it's really important, not that, we have too many leaders or not enough leaders, but really making sure across the board that the leaders are able to effectively manage the people that they supervise. You can find some areas that have way too many FTEs that are reporting to them, or you can on the flip side have it, lopsided the other way. And so really span of control studies are a great way to make sure things are equitable and equal across the playing field. And so those employees are getting enough touches from their, and direct supervision from their leader. And then the last thing I have on here, our future consideration, is looking at our job descriptions and consolidation. We probably have too many job descriptions. We've been creative over time. And so really looking at, an admin assistant in one department is likely the same or very similar to an admin in another department, admin assistant in another department. So should we not consider having one job description instead of having an admin assistant specific to a certain department? And so those are things that we're looking at doing in the future as well. All right, my last bit here is around total rewards, which is really our compensation and benefits team. If you recall, in our budget retreat and as part of our budget process last year, we had included a minimum wage adjustment to our budget. And so we are now implementing in March that adjustment from $17 to $18.50. This is going to be a big win for those lower wage earners. The current living wage, according to MIT's living wage calculator, is $23.45 in Tarrant County. We do know this will provide some meaningful wage increases for those lower wage earners. Also help, it's also a high turnover, type roles typically are in the lower wage earners. And so we want to make sure that we're able to hopefully retain and keep employees, because the cost of retraining and the cost of turnover we know is also significant. So I think this will be a great win for those staff members. Yeah.
On the, I'm working on a project over in Dallas, and they have the living wage, and they're making anything that's happening that's a Dallas County project. Whoever is hiring them, let's say for construction, like for our construction project, are we going to require the contractors that are employing, bringing in crews? Are we going to be requiring them to carry this $23.45 an hour?
So we're not going to 23.45, we're going to
So you
18.50,
just put the
sorry.
minimum wage, you're not adopting. We're not
Right.
We're
doing
Not
trying to,
adopting
yeah,
it.
we're
Okay.
trying to, you can still see we have a gap there that we're going to try to work to close.
Oh, okay.
And just how much we have in the budget that we can do that, I mean, that's a fairly heavy lift. How can we require, if we're not contracting directly with those subcontractors?
Connect you with someone over that's already doing this.
Okay,
On the, living.
So it'd have
wage.
to be at the contracting
Cause I think
level.
it's good because,
Yeah.
let's say I hire people, right?
Mhm.
We don't pay, and a lot of us that are in business, nobody's hardly paying anybody minimum wage, whether it's $17 or $18 an hour. You know, you're doing that Davis-Bacon or the Davis-Bacon or that prevailing wage, right? If it's in those contracts.
Mhm.
Everybody kind of exceed that. And you're right, you're gonna have, if people aren't getting paid, they're gonna go to another job for $1 more or 50 cents more. I mean, that's just the nature of it. But I think it's something we should consider. The living wage in Tarrant, if Dallas is doing it, Tarrant County should be doing it too, or all counties basically should be paying that living wage. And I would even share with you the package that they gave all of us to use in Dallas County on that project.
Okay. Love to see that.
Stop. But let me ask a question on that. So
I'm not
in
sure I can
Dallas,
support that.
Parkland is paying their entry level people. It's just contractors.
Dallas County.
It's Dallas County. Well, Parkland is in their county, and I'm just trying to figure out how that ties
I think
into.
it's the county, and that's, but you know, I'll check and see if Parkland, I'm not for sure if.
Yeah, I'm
Parkland-
just trying to figure out
I'll find out
for
more.
that.
Cynthia
Yeah.
will be there for a meeting, so I'll let
Yeah.
you know.
Okay. Yeah.
A lot of the events, it was tied into bond work, it was tied into state work.
Yeah. That's what I thought. You could do
This
it
is
on
all
that.
County, this is county, and it has nothing to do with federal or state. This is Dallas County.
Wow. Yeah. Let us see that.
I mean, just anybody, not just, I'm just using it as an example because I'm having to do it as a contract. I mean, I'm an employer and I'm having to do it. My
That's
company's having
interesting.
to do it.
Hmm. That is interesting. So yeah, give us some more information. Let's get some more information on that. Yeah.
But it's dictating.
Because it's kind of,
To be.
Yeah.
yeah.
On their contract and you get their welcome package, they're telling you, you're gonna
have to bring
file
it in?
your prevailing wages to LCP tracker.
Mhm.
You will pay your people our living wages.
Hmm.
You will do, I mean, it's
Mm.
pretty much the same thing that we're saying with our outreaches or what
Yeah.
you're telling Disney and
Yeah.
all these other people that we're doing business with. So it's not any different.
Mm. Okay.
I mean, I'm just saying.
Wow.
Yeah, let me know. If you guys are telling me I gotta pick it up at 23.
No, I'm sitting here looking and Karen back there when you said living wage, she changed on the side from one side to the other side. Now, that's expensive, so we'd have to really look at that.
To impose
Yeah.
on a private company.
Yeah,
So, Jill, here you brought something else to
I
start
have-
another
I'm sorry,
conversation.
yeah, last slide.
That's
I-
okay.
That
That's
is- I just wanted to
okay.
put that in there So you
I
guys
just
know
wanted to
where we have
provide-
to land, but that wasn't.
I wanted to provide a sample or an example of a total compensation statement. This is something that we all receive as employees on an annual basis. It's really important for staff to understand the other benefits that go along with their hourly rate as well. And so not only do we get them as existing employees, we do a version of this too with new hires because it's important for them to understand the other benefits. This is a fake person and we
Right.
put in some benefits and things like that. But I do think it's a nice example of all the things that we do for employees as part of their total compensation to work at JPS. This would be an example of someone who was probably making a little bit over $18.50 and some of their costs related to medical coverage based on their tiers and everything. So just wanted to provide this as an example, though. Again, I think it's important that our staff also knows all the benefits in addition to their earnings related to hourly rate.
I think that's a good idea because we never look at that other stuff that
Yeah,
they are
sometimes
getting.
people will say it's like, I'm leaving for 50 cents. And
We're
I'm thinking,
saying,
if you
you're
really
giving
look
up
at
this?
What the benefits are provided here, you're actually,
Mhm.
Well,
leaving money on
Should
the
be
table.
comparing,
Yeah.
right?
Yeah.
You should be
Yeah.
comparing.
Okay.
Do you know which of our health plans the 11,203 is for? We have multiple plans. Which one would that be? That's for any plan, that's how much we contribute.
That's for this particular plan. So this would be a lower, we have a tiered approach with how much we pay. And so this would be our contribution though. So we'd be making a little bit more of a contribution on a lower wage.
Looks like this one has a health savings account.
Yeah, they have an HSA account as well.
So this would be one of the HSA plans for a lower wage.
Yeah.
Yeah.
And they're paying $5, looks like a paycheck for health insurance. If it's 113 for the whole year,
Well, they're adding into their HSA as well.
and they're doing their HSA.
Yeah.
Mhm.
Yep.
Goes with their pocket, so
Yep.
makes it very affordable.
Wow, that's good.
Thanks to
Anyone?
Dorothy, we've held benefits. on our
Yes,
low
yes,
wage.
yeah. I'm telling you. Do anyone have any questions of Jill?
Thank you.
Good report, Jill. Thank you. Thank you very, very much. Okay. Do I have anything for closed session? All right, then. We have completed our meeting, so we are adjourned. All right. Thank y'all.
The gavel.
Oh, yeah, I use mine.